So here we're going to start a survey of some of the newborn neurological disorders here, and we're going to start out with hypoxic ischemic encephalopathy. This isn't something that's traditionally covered in a lot of USMLE reviews, but it's very clinically important. It's not tremendously uncommon in the NICU, and it's well, the reason I wanted to talk about it is the most common cause of neonatal seizures, which is going to be another thing we're going to talk about. That is something that's commonly tested on the USMLE. And it's something that's good to be aware of because it can lead to other problematic problems down the road. So we're going to cover that first. Then we'll go to neonatal seizures, how you treat that. There's some differences from adult seizures. It's really important that you need to be aware of that the USMLE will probably throw at you to try to trick you up. And then we'll talk about congenital hypotonia. And so that's going to cover part one. Part two, we'll talk about the neural tube defects, a couple malformations, and then also I'm going to address intraventricular hemorrhage, which is another possible sequelae of hypoxic ischemic encephalopathy. So HIE is a perfusion-reperfusion injury typically. It's a major cause of morbidity in the preterm infant. It pretty much always happens just in the preterm infant, not in term infants. It's also the leading cause of neonatal seizures. It's about 60%, so it causes the majority of neonatal seizures. Neonates lack that extensive autoregulatory mechanism of cerebral blood flow that's found in older children and adults. So for us, when our blood pressure goes up, our pressure in our cerebral pressure will adjust to that so that we don't have too high of blood pressure in the brain. And likewise, if our blood pressure goes down, our to that too. And so the cerebral pressure is very tightly regulated. However, in neonates, they don't quite have the same extent of regulation that we do, and so they're more susceptible to things like hypoxia, hypotension, hypertension, and so forth. So this is one factor which leads into hypoxic ischemic encephalopathy. Some of the things that can cause this are respiratory issues, so particularly birth hypoxia. That's going to lead to hypoxia to the brain. Blood pressure, whether it's hypotension or hypertension, either of those can lead to disturbances of cerebral blood flow. And then metabolic disturbances can affect oxygenation of the brain, and that also requires compensation of the vasculature. And like we've already said, that's not quite developed yet. Sufficient disturbances are going to overwhelm the neonate's ability to autoregulate cerebral perfusion, and that henceforth is going to result in ischemia. Now, the part of the brain that is most susceptible to hypoxia is this part of the brain that is right around the ventricles, the lateral ventricles, called the subependymal germinal matrix. And this is a layer of tissue in the brain that hasn't quite finished developing yet. It's a precursor to glial cells, sort of the glue of the brain. And these cells, because they haven't finished developing, they're chock full of mitochondria. And mitochondria, as you know, needs oxygen. And so because they're full of mitochondria, if they don't get the oxygen that they need, which is a very high amount of oxygen compared to other tissues, then these cells are going to go into programmed apoptosis. And when that happens, it can disrupt the vasculature around it, and that can lead to other problems, particularly the intraventricular hemorrhage that I alluded to earlier. In severe cases of HIE or of ischemia, that ischemic damage doesn't just go to the brain, it can extend beyond the brain. It can affect tissues like the heart, the liver, the kidneys, and so forth. So this is a sort of a schematic here of how HIE works and how this happens. Normally, you have autoregulation, but in neonates, that autoregulation can break down. So if there's hypercapnia, hypoxemia, acidosis, this is something that you would see in birth ischemia or birth hypoxia. Then if that persists, the blood pressure is going to drop. Ultimately, the cerebral blood flow drops. Likewise, if the blood pressure goes up, that's going to cause the cerebral blood flow to go up, and if that persists, you're going to have a breakdown of autoregulation, and that ultimately is going to lead to a drop in cerebral blood flow, and that is going to lead to ischemic brain injury. So whether you have an increased blood pressure, a decreased blood pressure, if you have hypercapnia, hypoxemia, acidosis, all of those things ultimately, if they're not treated fast enough, they can, and if they're severe enough, they can lead to ischemic brain injury. So the subependymal germinal matrix is right here. It's right next to the ventricles, and this is a very, very, very rapidly developing area of the brain, and it's very vascular. So if this area breaks down, it's liable to hemorrhage as well. So this area of the brain it's going to be the first part of the brain, typically, barring a stroke. This is going to be the first part of the brain that's going to go because it's so sensitive. So here's another schematic. So you have insult that leads to primary energy failure because the mitochondria aren't getting oxygen. At a cellular level, it's going to cause sodium overload within the cells. It's also going to cause increased calcium in the cells. That's also going to result in release of glutamate, which is an excitatory neurotransmitter. The apoptosis is going to release reactive oxygen species and nitric oxide. That can lead to things like seizures. And then the secondary phase is where you start getting the apoptosis, where you can get seizures, and ultimately you have ischemia. So the interventions need to be within 6 hours of the insult, otherwise you're going to have apoptosis no matter how you treat the baby. So you need to be treating the baby within 6 hours of insult. So it's very important to consider HIE anytime you have a baby who is premature. So the history of babies with HIE, typically they're going to be preterm neonates. All preterm neonates are at risk, particularly those who require resuscitation. So babies who required resuscitation typically had low APGAR scores. They were probably cyanotic at birth, and so that means that they're not getting enough oxygen. They were hypoxic for some period of time. Remember, birth hypoxia is our big risk factor here. Also, if they have acidosis or if they show any neurologic sequelae like hypotonia, seizures, lethargy, and coma, these babies are at risk. So you'll probably see that in the baby's history. The symptoms depend on the severity of the insult, so how much of the brain tissue was damaged. Most babies, pretty much all babies with this, are going to have poor feeding to some extent, irritability, crying, and lethargy, usually in cycling in cycles, so they'll be crying and irritable, and then they'll be lethargic and crying and irritable again. That's seen in pretty much all cases. Mild cases will show an increase in muscle tone and brisk deep tendon reflexes, and that reflects the hypoxic damage to the upper motor neurons that surround that germinal matrix. Moderate cases will show hypotonia, diminished DTRs, diminished neonatal reflexes. They can have seizures and possibly apnea. And in the very severe insults, these babies will be comatose. They'll have hypotonia, diminished DTRs. They can also be apneic to the point of where they need mechanical ventilation. Working up these babies, you need to work up absolutely everything that could possibly cause HIE. So we're thinking hypoxia, acidosis, metabolic disturbances, even looking at the heart, because if the heart isn't working properly, you can get hypoxia because you're not getting blood up into the brain. And you also want to look at the baby's coagulation, because if there are coagulation issues, that can also lead to bleeds in the brain, and ultimately that will lead to ischemia as well due to hemorrhage. So we're going to get a metabolic profile. You're going to want to include liver enzymes. We're also looking for other parts of the body that may have been injured because of hypoxia, so we want to look at the liver as well. We want to look at cardiac enzymes. In this case, it would be because possibly the heart was damaged because of the hypoxia. We want to get arterial blood gases, and that's going to help us determine whether or not we have a metabolic or respiratory acidosis. We want to get coagulation studies. Cranial ultrasound, that's going to be really important because of the association with HIE and periventricular and intraventricular hemorrhages. So in all babies who are preterm, you want to do a cranial ultrasound to screen them for intraventricular hemorrhage, but particularly in babies with suspected HIE. If that's positive, you also want to get you'll want to get a diffusion weighted MRI no matter what. So that's another study you'll probably want to do. And then echocardiography to assess the function of the heart. Otherwise, this is diagnosed clinically and in conjunction with your labs, but as I mentioned before, you need to be vigilant for signs of multi-organ dysfunction, particularly the liver and the lungs and the heart. There's about 80 to 85% of the babies who have HIE will also have some degree of hepatic injury, and also a majority of babies will also have pulmonary issues as well. There can be cardiac issues because of the hypoxia, and there can also be hematologic issues. As far as management for HIE, it's pretty much supportive. So you'll resuscitate these babies with fluid and electrolytes and stabilize their blood pressure. The mean arterial blood pressure needs to be kept above 40 millimeters of mercury to prevent hypoperfusion and further damage. Of course, you're going to want to have neonatology on board, that's obvious. They'll decide how you're going to feed them. You will probably want to have these babies on a 20-lead EEG with video monitoring, and that's going to help you see if there's any asymptomatic seizures. As we're going to see when we talk about neonatal seizures, a lot of times we don't see the clinical signs of seizures. We don't see the jerking necessarily, or certainly in most cases we're not going to see tonic-clonic events. So it's important to have an EEG on these babies because you can detect seizures that are asymptomatic, and those will need to be treated as well. You'll want to manage any concurrent complications, and then it's also going to be important to have an umbilical artery catheter in these babies. You'll have to confirm that with an X-ray. That'll be helpful for getting routine lab checks because you're going to need those. Immediate complications from HIE include seizures. It's the #1 cause of neonatal seizures, and then of course intraventricular hemorrhage. The long-term complications include cerebral palsy, epilepsy, cognitive deficits, blindness, and hearing impairments. Neonatal seizures are a big problem that are encountered in the NICU. The #1 cause is hypoxic ischemic encephalopathy, but infections, congenital diseases of metabolism are other causes. The manifestation of seizures in the neonate and the newborn are significantly different from those in older children and adults. So older children and adults, we think of, especially in children, we think of absent seizures. We think of partial seizures. In children and adults, we're particularly thinking about tonic-clonic seizures. That's not something that you see in neonates and newborns as much. The neonatal brain is relatively inhibitory. They have more inhibitory synapses compared to the more developed brain. And so tonic-clonic events are not as common in babies. So the manifestations are quite different, and a lot of times you're going to not be able to recognize the event. And so this is why it's very important in babies who are at risk for neonatal seizures to have them on an EEG for some time to monitor them. And there's an increased risk for neonatal seizures in premature babies. The etiology is diverse. The #1 etiology is cerebrovascular, so hypoxic ischemic encephalopathy is 60%, the #1 cause overall. Also intracranial hemorrhages, if the baby has subarachnoid hemorrhage, or if the baby has a intraventricular hemorrhage, that's something then that you'll want to look out for. Ischemic stroke is not something that's very commonly seen in babies, but that certainly would be another possible cause. If you have damage to part of the brain, that can be a focus for seizures. Infection includes bacterial meningitis, group B strep, E. coli, viral meningoencephalitis. Typically, these are going to present later, whereas these cerebrovascular causes are going to present within 6 to 24 hours of life. Intrauterine torch infections, particularly toxoplasmosis, that's another possibility. Metabolic, we're thinking of electrolyte disturbances, hypoglycemia, hypocalcemia, hypomagnesemia, or hypo or hypernatremia. Also, an inborn pyridoxine deficiency is a possibility. It's rare, but if the baby has a pyridoxine deficiency, this is typically going to lead to seizures that are very difficult to treat with our standard management, and so this is something to keep in mind. Amino acids or organic acid disorders can also be behind neonatal seizures. Other possible causes are drug withdrawal, cerebral dysgenesis, and benign family neonatal seizures is a diagnosis of exclusion. So the bold-faced etiologies here are higher yield for the USMLE. The symptoms of seizures in neonates can be extremely subtle, and oftentimes they're missed. Significant seizures can also occur in the absence of visible signs, and that's problematic because if a baby has significant seizures, that can lead to further damage. Some of the signs that you can see in neonatal seizures, and typically you don't see these signs in older people, include ocular deviation, eyelid fluttering, bicycling or swimming-like movements of the arms and legs, which can look very similar to just spontaneous motions, lip smacking, sucking, or other oral tics. They can also have apneic episodes as well. Neonates rarely have tonic-clonic seizures, as mentioned, and most neonatal seizures will occur between 12 and 48 hours of life, and those are going to be the seizures that are associated with ischemia or hemorrhage. If a newborn baby has a seizure and it's the first seizure is presenting after 48 hours of life, that's more likely to be infectious or metabolic in origin. Not always, but if the baby is older, then we're looking more at infections and metabolic disorders. The workup for neonatal seizures, because there's so many causes, the workup is going to be extensive. So you'll want to get a metabolic panel, including calcium, magnesium levels. So we're looking at those electrolytes. That's a big cause of seizures that can be easily treated. You'll also want to have torch titers, and then you'll assess the baby for amino acids and organic acids. Those are those metabolic disorders. For amino acids, you can test those in the serum. Organic acids can be tested in the urine. Cranial sonography is very important for preterm babies because we're looking at intraventricular hemorrhage. Sonography is going to be your best first step. If that's negative, you probably don't need to do anything. But if it shows that there's bleed, then you'll want to follow that up with an MRI. A lumbar puncture is appropriate to do in babies that don't have any contraindication for lumbar puncture. So you'll get a lumbar puncture. You're looking at the color of the cerebral spinal fluid. If there's a yellow color, that suggests blood breakdown, and that would suggest a subarachnoid hemorrhage. If there's glucose, low glucose, that's going to suggest bacterial meningitis. Just remember thinking it's the bacteria eating the sugar in the cerebral spinal fluid, and so it's low. You'll also want to get a PCR for HSV because meningoencephalitis can cause seizures as well. A video 20-lead EEG is useful if you suspect the baby has seizures. You may not detect another one on your own, so getting that video EEG is going to be helpful to find any seizure events that are subclinical or that are happening when nobody's around. And then an echocardiogram is usually ordered as well. So the contraindications for LP. It's important to know this, not just for neonatal medicine and pediatrics, but also for adult medicine. The absolute contraindications for lumbar puncture are going to be a midline shift, a posterior fossa mass, and a loss of cisterns. The problem is that you're only going to know that these contraindications exist if you get a CT. This is typically going to be in patients who have papilledema, have signs of increased intracerebral pressure, or have a history of trauma. So that gives rise to these relative contraindications here. If the patient has signs of increased intracranial pressure, then those are things like papilledema, Charcot's triad, which is bradycardia, Charcot's triad, Cushing's triad, sorry. Bradycardia with increased systolic pressure and widened pulse pressure. That's going to be a sign of intracranial pressure increase, and then hydrocephalus. So if any of these exist, you'll want to get a CT before you get a lumbar puncture. If there's coagulopathy, certainly you are going to be concerned about doing a lumbar puncture, and then if there's a brain abscess, that's going to be another concern. It's always also a relative contraindication to get a lumbar puncture if the person has had a seizure within the past week, and that's going to require a CT or MRI before you get the lumbar puncture. So because here we're talking about neonatal seizures, and part of our workup is a lumbar puncture, well, you're going to have to get a CT then, or an MRI, either or, to assess for any absolute contraindications. So in any baby who you're working up for neonatal seizures, you're going to do some kind of imaging to make sure they don't have any contraindications. So hopefully I made that clear. So please note that while the first line of treatment in adults and most children, generally children above the age of 1, is benzodiazepines like Ativan, this is not the case in newborns, and that's because their brains are different. So the management in neonatal seizures, just like in adult seizures, first you're going to check your ABCs, make sure that the patient is ventilating appropriately, perfusing appropriately. You want to monitor their pulse oximetry and their blood pressure. You also want to get an immediate glucose and electrolyte levels, particularly glucose. Hypoglycemic seizures are not terribly uncommon, so you get that heel stick glucose. If it's low, particularly below 40, then you'll correct the glucose with 2 mL per kg of D10 water, and then you can drip D10 water after that. You also want to correct any electrolyte abnormalities that are present as well, but typically that's going to take a little time to get those back. The first line of therapy in neonatal seizures is phenobarbital. So yes, we use barbiturates first in neonatal seizures, and that's the opposite of adult seizures, where you give benzodiazepines first, and if that's not successful, then you give phenobarbital. In neonates, you give phenobarbital first, and if that's not successful, then you can go on to give either anti-epileptic drugs like phenytoin, or you can give lorazepam, benzodiazepine. So the first line of treatment is IV phenobarbital, 20 milliliters per kilogram. You can continue, if it's not effective, you can continue giving doses in 5 ml per kg increments. So if you've got a 1.5 1,500 gram baby, you'll give 7.5 mils per kg in increments, and we're hoping that the seizure resolves. You can give them in 7.5 mils per kilogram increments if it's a 1,500 gram baby. If it's a 1 gram baby, you'll give 5 mils per kg, and you can do this up to 40 mils per kg total. So you can give 4 additional dosages of 5 milliliter per kilogram increments. After that, the second line treatment is fosphenytoin or lorazepam, and then intractable seizures should be treated with IV or intramuscular pyridoxine. Now, I'm not sure, since I'm not a pediatrician, I'm not sure, personally, if it was me, I would think that, maybe useful to just give intramuscular pyridoxine immediately, just in case that's the possibility, because it's difficult to overdose on pyridoxine if the baby truly has a deficiency. but you may want to ask a pediatrician that. But that may be part of something that you can do immediately. You might not have to wait, 10, 15, 20 minutes to give the pyridoxine. Because I put it down here, I'm not necessarily saying that you have to wait until you've, given first-line treatment, second-line treatment. That may be something that you can do in conjunction with your phenobarbital. But remember that pyridoxine deficiency can lead to seizures, so that can be part of your treatment if your sedatives like phenobarbital and lorazepam haven't worked. And any baby that's having seizures, you'll want to consult neonatology and pediatric neurology. Congenital hypotonia is something that's a little less tested on the USMLE, but I still wanted to test it, or I still wanted to touch on it. So hypotonia can occur due to a dysfunction anywhere along the neural axis. So we're talking about the upper motor neurons all the way down to the neuromuscular junction and the muscle itself. A normal infant, when you hold a baby, neonate, if you hold the baby in horizontal suspension, so you're holding the baby in your hands, the head should be held in extension, and the back should be straight, elbows should be flexed, and the knee should be partially flexed. The baby should look like Superman. It shouldn't be slumping over in like a upside down U shape. When you hold the baby in vertical suspension, so you're holding the baby underneath their armpits, they should be stable that way. In a baby with hypotonia, if you try to hold the baby underneath their armpits, they're going to slide right out. And then if you take the baby and bring them from laying down in a supine position to sitting up, they should keep their head in about the same position. A baby with hypotonia will not be able to do these things. The number one cause of acquired hypotonia, again, here we see it again, is hypoxic ischemic encephalopathy. The number one cause of congenital hypotonia is Down syndrome. So here's a baby with hypotonia. See this baby here? This is a normal baby. Looks like Superman flying in the air. This baby is kind of droopy. Looks like he's sleeping. Upside down U shape. This is hypotonia. Another one here. You see this a lot in Down syndrome babies. Upper motor neuron etiologies, so there's a lot of them. Structurally, it's hypoxic ischemic encephalopathy is number one. Of course, we already talked about this. It's associated with preemies, asphyxia, limpness, stupor, poor cry, poor DTRs, irritability. They can have increased tone, increased DTRs, especially if they have mild disease. Seizures can be present as well and often are present. They can also have brain malformations, can be another cause of hypotonia. The syndromes, you've got Down syndrome, which in that case you oftentimes see the characteristic facies, congenital heart defects, especially atrial septal defects, ventricular septal defects, older mother. The Prader-Willi syndrome, these babies tend to be larger, they have hypogonadism. Marfan syndrome, they tend to have longer fingers. Turner syndrome, tend to have neck webbing, congenital heart defects, and renal anomalies. Dysautonomia, this isn't really common, but these babies have respiratory infections. Also, if you touch their eyes, they're not going to be able to feel anything, so they won't blink or start crying. Degenerative diseases include Tay-Sachs, that is characterized by the characteristic cherry red macula. These babies also tend to be of Ashkenazic Jewish origin. Metachromatic leukodystrophy, I don't think the test is going to ask you about that. Systemic disorders and metabolic diseases, malnutrition, this can be associated with cystic fibrosis, hypothyroidism, hypercalcemia. Remember, calcium is a stabilizing electrolyte. So if you don't have enough calcium, if you're hypocalcemic, you're going to be irritable, jittery, touchy. You can have seizures, you're going to have increased reflexes. If you're hypercalcemic, you're going to be hypotonic, lethargic, decreased reflexes. So calcium is stabilizing, and to the point where it can be sedating if you have too much. And then these mitochondrial diseases, Lowe's disease, Pompey's disease, and Lay's disease, these are relatively low yield for the test. So these are your upper motor neuron etiologies. Lower motor neuron etiologies include spinal muscular atrophy. These babies have a weak cry, absent deep tendon reflexes. They also tend to have tongue fasciculations, decreased spontaneous movements, and delay in gross motor milestones. But usually you're not going to see these babies present in the neonatal period. Same with infantile botulism. These babies usually get botulism because the parents are unaware that you cannot feed your baby honey. I told my mom this, right? Like, you can't give your baby honey. Did you know that you can't do that? And she said, "Oh no, I didn't know that." And I'm just thinking, wow, mom could have given me botulism. So history of honey consumption, very big in history of a baby, especially an older baby under 1 year of age, but an older baby that comes in who's hypotonic. These babies tend to feed poorly. They tend to have constipation, weak cry, lethargy, facial weakness. They're just weak all around. You can also get botulism from soil dust, but I would expect on the USMLE, they're going to give you that history of honey consumption. And the treatment for these babies is supportive. Myasthenia gravis looks just like infantile botulism, and so one of the ways that you can, I guess the history helps too, but one of the ways that you can tell these two apart is by you can perform an EMG. And then these other ones are rarely tested. There's myotonic dystrophy, neonatal congenital myopathy, congenital muscular dystrophy, hypomyelinating infantile neuropathy, and then this diagnosis of exclusion here, which is benign congenital hypotonia. I don't think you're going to be asked to differentiate between any of these, but these bold-faced ones you should be aware of. And same here. So these bold-faced ones, these do come up in USMLE often. But I wouldn't expect that you're going to get asked about Lowe's disease or Pompey's disease in the setting of congenital hypotonia. I might be wrong, but I've never seen any questions that test that.